So thank you very much for this opportunity to just give a kind of quick taste and flavour of some of the things that have been coming out from the Dallas evaluation. I will be, obviously, some of the things I say I'm going to rush through because they'll be resonating. We've touched them already in the panel, so I don't want to belabor them. But this essentially is just going to be giving the highlights. And essentially, Dallas has been a journey. It's been a journey for the communities and also for the evaluation team as well. And I think it's important to be clear that in terms of evaluation, the aims of our evaluation is really been to get an overview of the ecosystem, the whole system in which the Dallas program has been rolled out in terms of the effect, what's happened with the public and the consumers who've been engaged, with health professionals, with the organizations, in terms of processes, with industry players, with the market, and what have been the key issues in the program. And if we look at the top area there in terms of the translational gap, there's an issue about, always has been that we know that even if something is proven to be effective, if it's done a pilot or it's done in a trial, whether it's telemedicine or telecare or an app or computerized decision support system, that often when it comes to after the trial is done or the pilot period is over, that it doesn't become changed into a real service. It doesn't become a normalized part of a healthcare delivery that's embedded and integrated into everybody's everyday work. And that translational gap has been a big problem, certainly for those interested in digital healthcare. And it's one of the things that we wanted to be able to look at and learn about through the Dallas program, which has provided an excellent opportunity for that. If we then move along to this picture here, I think this actually captures quite well the journey for the Dallas communities who've actually had lots of obstacles. So as I've kind of mentioned earlier, sometimes companies have gone bankrupt that they've been working with. Sometimes there have been major partners who have withdrawn. Then it was also happening in the background of not only austerity, but the complete restructuring of NHS England. So lots and lots of challenges out there. And of course, when you do co-design, you'll find some things that work and some things that don't work so well. So some ideas have been discarded and things and directions have been changed. And there's really a great deal to be learned from that. And that is what the Dallas evaluation has been about. It's from the outset, Dallas was not conceived of as a clinical trial or a randomized controlled trial. It doesn't have controlled conditions. There wasn't a single intervention or process that we were going to prove the benefit of X or Y. There was a whole suite of different products and services that were being rolled out and tested to see what worked and what didn't work. And essentially, we've had the opportunity to be the kind of fly on the wall, documenting that over 3 years longitudinally, involving lots of stakeholders, people from voluntary sector, public, others, professionals, those who have been the key implementers, those from industry, to try and see what is it that has succeeded, what has done less well, how were barriers overcome, and see what are the key kind of learning messages that can come out from the program. If we look along to methods, well, our evaluation has been a mixed methods evaluation. We have collected a huge amount of qualitative and survey data from people involved in the program, as I say, involving consumers, people involved in co-design, people using services, involving professionals, but also people from industry, people from voluntary sector, academics who might have been involved in the program, all of these different people. So we've done qualitative interviews or surveys or observational work with over 600 people. We've also collected quantitative data from over 10,000 people in terms of, to give us an idea of the reach of the service, in terms of socio-demographics of those who use different products and services, and also work in terms of how the public valued the 6 C's and about willingness to pay for products and services, as well as looking about how easy they were to use or otherwise. And if we look down at this kind of jigsaw puzzle there about thinking about the doing, one of the things that we've had in the Dallas journey in our evaluation has been to use a theoretical framework called normalization process theory. It's a sociological theory that's really about how do you move new services, technologies, innovations, new ways of working, how do you move them, get them to become part of everyday practice? And me being a GP and kind of a simple person, I liked it because it focuses on the work that people actually have to do. And it has 4 constructs. Some of it can be thought about the first two, coherence and cognitive participation, about thinking about the doing, and the other two, collective action and reflexive monitoring, very much about doing the doing. So these constructs as coherence is what's the sense-making work that people have to do? How do they make sense of it? Do they have a shared vision of the direction of travel? What's the engagement work that you have to do to get people to champion your new service and products and cognitive participation? What is the work that has to be done to see if people can sustain their involvement in a program? But also collective action. What is the work that actually required? What money is required? What finances and resources? What technologies, what infrastructure is needed? What training and skills and support will people need to be able to actually operationalize new ways of working, new technologies? And reflexive monitoring is a bit like, I suppose, touching on the co-design type issues is about how is success judged? How do people change the systems as they're rolled out? How is there an iterative program of development? And how does this help affect the implementation journey? So we've used this as our underpinning conceptual framework throughout the 3 years of the project, and it has been a consistent feature. So if we move forward onto the lessons learned and focus in on that slide, I'm just going to tell you a little bit of what we've been learning about readiness in terms of the ecosystem for digital healthcare from the experiences within Dallas. And really, as I said on the clip in the film there, really we've looked at 3 levels of that. There's the kind of very macro environment, the meso and the micro. So when I'm talking about the macro environment, it's thinking about what's the market like? Is the market ready? What are the policy and legislation? And what's the infrastructure issues? And how ready are those for digital healthcare when trying to deliver it at scale? And one of the things that's come up in the conversations has been that of interoperability and how important that is. And what is the market readiness for interoperability? And of course, iFocus had responsibility for trying to promote interoperability and move that agenda forward, and they've been very successful in that and doing, and have really shown to a great extent that technical problems are not the big barrier to interoperability. But if you're a company, if you're the market and you're interested in interoperability, or you're interested in digital health really, the question for industry is, are you going to spend your time trying to make sure your products and services are interoperative and will work with others? Or are you going to invest more of your time in trying to increase your market share? What is your priority? And this certainly is an issue for us and what we've seen in the DALS program in terms of digital readiness of the market. But also another issue that came up here was that of information governance and looking at the legislation that exists. If you start moving into the realm of personal health records and you're talking about who owns the data, and we have information governance legislation and privacy legislation in this country which is meant to protect patients and keep our data safe. But really, in a sense, for DALS, that's been a big problem in terms of how those legislation just now is interpreted across the country. So, for instance, if you're talking about personal health records, if I have my personal health record to help me manage my diabetes, and then I keep maintaining that, that's fine, it's my property. But as soon as a health professional writes in that record, then it becomes the property of the NHS. So these are issues that have been, in terms of the wider, the macro level issues that have affected. But also the infrastructure. In terms of DALS was across the UK, across Scotland and England, in remote and rural locations as well as urban. And certainly there's still problems in terms of broadband availability. And not even just thinking about broadband, remote and rural area, but just like Wi-Fi. If you're going to have an e-read book or a digital app that you're going to use in your health centre, if they don't have Wi-Fi, it means they can't, it's a non-starter. So this was in the kind of macro environment, certainly some issues that have come up. Thinking about meso environment, about the individual companies and about individual hospitals and organisations and about the technical infrastructure. Many of our NHS hospitals have legacy IT systems that make them difficult to embrace change and to make progress. They also have systems with firewalls that make it difficult sometimes for them to interact with other apps or other devices that want to feed in information to them, and that's an ongoing problem. But also if you think about industry and risk, we talked a bit about risk earlier. It's all very well when you have a pedometer that's an app that somebody can look to measure their activity, but when you move into the realm of maybe putting sensors in a home of somebody who's frail and elderly and they're going to be to get their loved ones to be more connected to them, to be able to watch and monitor their well-being, there becomes an issue of liability. If that product does not work, you're in fact doing more than providing a product and essentially providing a service, and who's going to be liable for that? Now, if we're trying to get the Asda's and the Tesco's and the John Lewis to move into this kind of healthcare sector and digital health, some of these companies are a bit risk averse. They're kind of thinking, is that a responsibility that we want to take? And certainly that's been an issue that's been noted in the Dallas program as well. So the readiness for industry who are not traditionally in the health and social care sector to interact with what they see as the statutory sector and perhaps get liabilities that they have not been used to assuming. But also the issue of continuity in NHS organisations. And it was clear that constant change was an issue. And if you're in an organisation and the chief executive changes, there's 6 different chief executives in 2 years, then that is also a problem when you're trying to drive change and trying to drive programs. So the readiness of the organisations that Dallas members were involved with was also a problem. But also when you turn to the micro level, and we've been talking about this quite a bit in the panel there, there's the readiness of both health professionals and the public to engage with these technologies. And I think there's a kind of assumption out there that most health professionals are reticent and they hold back the system, and that the public are gung-ho and all for it. And I think there's a bit of yes and no to that, and that's a bit of an oversimplification. I think one thing that's been clear from the Dallas program is that in terms of health professional readiness, there's a skills deficiency for our health professionals for rolling out apps and services, and I think that was brought out very clearly as being a problem. And then turning to the public, well, there's an issue there about, we've talked about the skills deficiency, we've talked about the efforts that some of the communities have gone to in terms of digital champions and trying to be enabling. And certainly there was a clear message that while many members of the public were very open and very enthusiastic about new technologies and the potential services that were offered through the Dallas program, lots of people need help to actually utilize those services. And then there's the issue about risk and confidentiality and safety. And that's something that also has been an issue for the public who've been engaging with Dallas products and services. So, for instance, when you talk about eRed Book, there were some parents who might be reluctant to say that they wanted to put their child's data onto an electronic system, and what would be the data security issues for that in the longer term. But also that people sometimes felt that they wanted the endorsement of the NHS or health professionals if they were going to have their own personal health record, that maybe they needed that kind of professional endorsement. So, what are the implications of that going forward, and what are some of the recommendations that we've been suggesting to Innovate stemming from the work we've done and our analysis? Well, I think the first one is relating to the security and the safety issue. And if you think about that, the issue that John Eagleston's been talking about accreditation and kite marking, I think that we do need some way of making sure the public realize that any type of app or anything they're using, whether it's safe or not. Of course, as again I say, when you're talking about well-being apps and about monitoring how much food you eat or your calorie intake, that's one thing. But if you have an app that's telling you what you should do if your asthma control is getting worse and when you should seek help, people want to know that the advice that's being given in that, and health professionals equally want to know that it's safe to recommend it. And I think that one of the recommendations we've had going forward is that really there needs to be some system or process for kite marking or accreditation or something to help that. You know, I point people to NHS Choices website and give them information and tell them to go to information there because I know that the information there is correct. And I think we do need some way of have a system that's put into place to address that. If we then move on to types of policy, well, it's clearly very true that information governance, regulations aren't really fit for purpose for the ambitions that people in Dallas had and going forward. And I think there does need to be revisiting in terms of legislation. What are going to be our rules about who owns what data, about data sharing going forward? And I think at a policy level that does need revisited. Equally, if we think about IT and infrastructure, well, I'm very glad the Prime Minister has said made a commitment to fast broadband by 2020 across the UK. But clearly, I think that's a big priority, that, but also, as I said before, it's not just the broadband in remote and rural areas, it's also in urban areas and the hospitals and the health centres that we have, making them digitally enabled. There may be Wi-Fi, but if it's not very good or it's not very effective, well, it's kind of worse than useless. If we then move along to thinking about business and industry, we all say that interoperability is an important thing, and I think that it has to be some consideration about how we're going to incentivize that for industry, that they will see that that's actually something that's beneficial to them. Thinking about the public more widely, we've already had the panel talking about the work of engagement and about upskilling, and I think that's definitely an important thing, that, you know, if you just put out the tools and technologies, then it's going to reach some of the public, but you have a risk of widening inequalities. That's not a reason not to progress the digital healthcare agenda, but it does mean that it needs to put time and money and effort into that digital engagement. And you talk about Liverpool and the hubs that they have, their digital hubs, and about the work they've done. And they've only reached some of the people of Liverpool, so that's an ongoing, a work in progress. So there has to be the realization that considerable investment has to be going into upskilling, but not just of the public, but also of health professionals. There is a big disconnect. We have junior doctors, we have medical students and nurses who all use their iPhones and all their smart apps and devices, but there's a disconnect with what they're using in their everyday life and how they apply that to healthcare. And we certainly been recommending one of the lessons, again, coming from the Dallas program, is that undergraduate medical and health professional education really needs to have digital healthcare kind of front and center as a part of the core curriculum. Because just now, traditional medical schools don't necessarily see that as something. It's still about diseases and learning management pathways, and it's not to say, obviously, that's essential. You want your doctor to know how to manage your heart failure properly. But I think there needs to be a little bit more emphasis about how health professionals can be trained up to help patients and the public and consumers and caregivers, to help point them the way and assist them in digital healthcare. So those are the kind of the main messages we have. Some of these have been already brought up by the panel and discussed, but those are kind of just some of the highlights I'd like to bring to your attention today. On your leaflet that you have, there is a publication that we had out in JAMIA. The full date of that was out in August, which was some of the big implementation lessons. And we will be coming forth with more publications which will be talking about these readiness issues I've discussed here, but also some of the health economic work as well. Thank you.
So we're a bit tight on time, but if there's a couple of quick questions before we hand over to the panel session, anyone want to ask any particular questions? So, we have one from. Oh, sorry. Sorry.
Would you like to take questions?
Yeah, by all means. One question.
Can I have a very brief question, if I may? I'm a retired ex-pharmacist and I live in West Yorkshire in Huddersfield. I just want to ask a few very brief, without being too cynical or critical about you. I have attended a few of your conferences, so after talking to some people outside, and I have my own jaundiced view, is this. You people have been running this 2-3 years, and in your video, second part of the video, if I remember, I stand to be corrected, where one of the presenters said that it takes 17 years to implement and get approved. I can't believe that. So if that is the case, have you ever looked into the continent, how these people are doing better or worse, and use that rather than reinventing the wheel? Now, coming back to the speaker just said about the IT and all that. I'll tell you one typical example about disconnect in this country about the IT. I have my health problems, so I managed to get from my GP a referral to one of the London hospital consultants. So I had my blood test done locally, and that could not be transmitted to the London hospital, even by IT or even by fax. And they have to speak it, put it on the phone after 3 days of trying. So can you see my concern about the IT and in this country, while you people talk about all the apps and all the things? I hope I put my point quite reasonably clear.
Okay, so I think the question is about adoption, speed of adoption, and then also about how that fits with the data security.
Yeah. I think probably I should say you need to move to Scotland, because where I work as a GP there, when we'd order a blood test, it's on a portal. So actually the doctors in the hospital can see the tests, and I can also see the lab tests. So in this country, I suppose whether you're talking about in the devolved nations or across the whole of the UK. So I think it's patchy. And I think what we want is all hospitals and primary care communities to be in that same sector, so that the data sharing is information. I don't think we need much evidence or randomized controlled trials again to show that that would be helpful. It's just common sense that actually being able to access information like that more easily is the way forward. And that has already been achieved in Scotland, of course, with their portal. And I know that's the aspiration in England as well for areas.
So I suggest we take a few words from Carl, and then we'll hand over to Winifred for the panel. So.
I'm conscious of time, so I'll keep this fairly brief, but I just wanted to say a few words about some of the work that we've been doing at DataBuild. I'm an associate director at DataBuild, and we're a research consultancy that specialises in the evaluation of programs, government-funded programs and initiatives such as Dallas. And we've been working in parallel with Francis and the University of Glasgow on the evaluation work, with a particular emphasis on looking at the market impacts and what wealth creation opportunities might emerge as a result of Dallas. Our work's involved a three-stage process, a baseline evaluation at the very outset of the programme, an interim evaluation that was conducted last year, and we're in the process of completing our final evaluation at the moment, with the report on that likely to be due out in the new year. Over that time, we've spoken to a number of individuals, both within the Dallas communities and the organisations participating in the communities, but also organisations outside of those, similar organisations outside, and that's across the private, public and third sectors, to really find out what's been going on in the market over the time that Dallas has been in place. We've also been consulting with a particular viewpoint on what's happening in the market, and trying to get their views and feedback to inform our work. As I said, our work's still ongoing, so there's a limit to what I can tell you today, but there were a couple of things emerging from the final evaluation that I felt would be useful to share with you. The first and perhaps most important point is that what we're finding is that it's largely too early to tell, really, at this stage, what the impact of Dallas might be on the market and what wealth creation might emerge. I think a number of people that we've been speaking to have been pointing towards areas where they expect to see growth and opportunities in the future, but a lot of that hasn't necessarily been realised as yet. And what you'll have heard others on the panel talking about earlier is that there are a number of ongoing opportunities that are being progressed. Additional funding has been secured to take some of those opportunities forward. And what's been really valuable out of the Dallas process, what people are reporting to us, is that they've had this opportunity to come together in a context and in a way, getting organisations to work together that wouldn't ordinarily work together in this way, to innovate in a context where they're free from some of the constraints that a randomised controlled trial approach might bring. So they're free to innovate more around the service design and service use. They're not constrained in that way. And also to then do things without necessarily having the same financial risks associated with it, because of the funding from Innovate UK and the investment being made that takes some of the risk out of that for some of the private sector companies in particular. I think what's also come out of our work is that people are still reporting there are a number of barriers still to be overcome, really, to realise the full kind of wealth creation benefits that could emerge from the kinds of products and services that have been taken forward under Dallas. And SMEs in particular that we've spoken to are still reporting, well, they're still finding that there are barriers that they're not necessarily being able to overcome in terms of selling to the statutory market in particular and getting through the procurement process. If they're not a kind of known supplier that is in a position to benefit from that, then they're not necessarily able to commercialize their ideas and their service offerings as much and as readily as they might wish. And that's a particular challenge and an important point, because one of the opportunities I think that SMEs saw within Dallas was to trial something in the UK context that would actually put them towards a position where they were really a market leader globally that could then start to export these services and ideas and begin to generate revenue that way. So some of the wealth creation opportunities aren't necessarily being realized just as yet. But I think what Dallas has demonstrated is various ways in which digital as a thing can be embedded within health and social care service delivery, and how these services might be reimagined. So it's now a question of what happens next, and I think that's a question of the evidence and learnings emerging from the Dallas process, and then the organisations that have been working within Dallas taking those ideas, that evidence forward into future service offerings, and those of you in this room as well that are in a position to do so, how you respond to the evidence that comes out of the Dallas process. So I'll leave it there, but thank you very much.
Okay, so now the next panel, which Winifred will run us through, is thinking about how do we take some of this forward. So, Winifred, over to you.
Can you hear me all right?
Yes.
Yeah, great. I'm Winifred Robinson. I present You and Yours on Radio 4, which is a consumer programme. And I've been asked here today really because we do a lot about care and the quality of care. Just this week we had a phone-in which was asking the question whether the current care system is sustainable. And we had a woman who has a carer who comes in at 10 and doesn't come back until 9 o'clock, explaining that she is doubly incontinent and sometimes is lying in soil pads, you know, for those hours waiting for somebody to come. So on the one hand, we've got that, which is a system that seems to be just about keeping people going, isn't it? We talk about safeguarding, making sure that people don't die. And then on the other hand, we have this terrific ambition about what we might be able to do. So this week we've had just today, a reporter in Japan on the motorway in a driverless car. And the makers of that car talking about the fact that that technology is for assisted living. We had Sir James Dyson interviewed this week talking about the fact that he uses a hearing aid which costs £3,500, and he doesn't know why they don't make the profit by delivering that hearing aid at scale rather than making a lot of profit on the very few that people can afford to buy. Soon there'll be lots and lots of us who are old who are not even remotely scared of technology. And so what always strikes me about these conferences is trying to bridge the gap between what we currently do and what we have ambitions to do. This is your chance to speak. So I will briefly introduce the panel to you, and then really you have kind of half an hour to talk. And I know you've listened a lot. So let me just quickly just be a bit like calling the register. But everybody here on my left has a budget to spend, is in a position of authority, and knows a lot about assisted technologies. John Rouse is Director General Social Care, Local Government and Care Partnerships at the Department of Health. If you just show your hand. So his responsibilities include policies on care and support for adults, the Department of Health's relationship with local government across all health and care. And Professor Clive Morris is the Director of Health Innovation Manchester. So he leads the creation of a big new health and life sciences initiative. It's bringing together health and social care, academic and industrial sectors across Greater Manchester, trying to drive innovation and improve healthcare. Farid Bidgoli is from a big international drugs company which does a lot of research and development. It's called Merck, Sharp and Dome. But before he joined them, he's an expert in using technology to deliver better care for people with chronic illnesses. And he worked with the NHS England. He's particularly good at how you use data to improve care. And Professor Donald O'Donoghue is Professor of Renal Medicine at Manchester University, and he's been a consultant in Salford since 1992, but he became National Director of Kidney Care in 2007. He's also a member of the Liverpool Clinical Commissioning Group. Zahid Latif is Head of Health and Care at Innovate UK. You've met him already today, I hope. Dr. Linda McGee is the Chief Operating Officer of the Manchester Academic Health Science Centre. And in 2000, she started up the North West Region's Biomedical Cluster. It's one of the largest in the UK, so it supports and promotes biotechnology, pharmaceutical, healthcare, industry sectors, alongside academic research and clinical communities. And then Dr. Kevin Doughty is Director of the Centre for Usable Home Technology at Coventry University. I think that's kind of self-explanatory. And he has 30 years' experience in the assisted living technology industry. I just want to put them on the spot because this conference is about taking ideas away and then doing something. So I just thought if I could go from left to right, if you would tell me what you will take away today and what you will do, perhaps in a sentence or two. Could I start with you, John?
So I was really interested in the last speaker and the need to bring SMEs more clearly into this space and enable them to develop their products and their companies. And so I'm going to think about how we might work with the catapult centres that already exist around the country that maybe can help us take some of the early technology development and bring it to commercialisation.
I'm really interested in iFocus and their agenda around interoperability. I think it's really key and important that anyone who's developing anything, whether it be a wearable, whether it be an app, that actually thinks about the workflow for physicians in healthcare settings to make sure that actually it doesn't become an additional barrier to adoption of technology. So I think it's great work that iFocus is doing.
For me, I've been tracking and watching the Dallas projects for a while. I think we're hitting a timely point because the government, through the Department of Health, are doing the Accelerated Access Review, where they're looking at how do they accelerate that time frame from, typically was being bandied around the 17-year time frame to getting an idea from the market and into clinical practice. I'd like to, there's a lot of discussions around what digital technologies could do for healthcare, and not necessarily just about adding costs, but being ways of being able to manage the deficit that needs to be achieved. And I think David Horsfield talked about how clinicians within Liverpool are prescribing some of the digital solutions, and actually that's it seems really basic, but it's a fundamental issue around how do you get the clinicians access to these things, because just the fundamental processes of being able to look through your list and go, oh, that's on the list, I could possibly prescribe that to this patient, is a really it's a real sort of barrier to try to get this stuff.
So you know we're short of time.
Sorry.
As Health Innovation Manchester, one of the things we're very keen on is how can we both discover new interventions, test and validate them, but also implement them across the whole of Greater Manchester and do that quickly. So one of the bits, I guess, as we start looking at outcomes from the various pilots that have already been done across the 4 initiatives, what are the things where the data is actually compelling that says actually we should just be getting on with this now and actually getting on and implementing them? So it sounds like, middle of December there's more data out there, so I guess early in the new year we can look at those and see, are there some that are ready to go?
Linda, what will you take and what will you do?
It's a compliment to John, to what John said, really. I'm very focused around SMEs, and it's about engaging with the citizen, the wider community, the third sector, and the co-design work that's been done.
Hi.
So I guess I'll take that we're definitely in the knowledge business rather than in the real estate business. And what I'll try and do is to take some of the lessons so that we can address the question that Mark Gunn was asking before about the productivity question, which is a key issue for our system at the moment. And I think it would be naive to believe that we could get all the answers from the diverse arrangements that happened in Dallas, but we'll get quite a lot of signal there, I think, and we'll have to be as confident as the people in Liverpool that invested the 15 million, which is only over 2 years. It's less than 1% of the spend. So clearly, we're going to go moving into a digital age, and we need to embrace that.
Donna?
I'd like to develop both supply and knowledge chains, moving right from the consumer through to who can deliver. So that includes the SMEs and clusters and the commissioner. so that they all benefit from the community spirit that we've seen in places like Liverpool.
Okay, lovely. I want to open it to you now, please. So if you would just show your hand, we'll get a mic to you. Doesn't have to be a question. You might just want to say something. Doesn't have to be to this panel. Obviously, we've got the people here from the different projects. A gentleman at the back.
Hi, my name's Daniel Heary. I work for a social enterprise in Cumbria, and we've done some telehealth projects over the past 7 or 8 years. One of the things that we find to be a really big challenge is a lot of money goes into the acute trust in Cumbria, in North Cumbria, and it seems that they don't really have any ambition to reduce the number of admissions, and that seems to feed back through the system. So when we go out and try and present a new service that's really innovative, the patients love, it just seems to get blocked by the system. And I just wondered what, if any of the Dallas pilots had experienced any of those sorts of scenarios, or if it was just a Cumbria issue.
Yeah, so without being too specific, I mean, we've certainly experienced that, and that we would see that as being part of the sort of remuneration based on activity. It really militates against the kinds of models that were being talked about this morning, where there's this really looking at what's right for the person over the longer term. However, we have seen some encouraging signs within Leeds, for example, where the acutes and the CCGs and the community health and providers have come to an agreement that there is actually a significant amount of high-cost, low-value activity that can sensibly be taken out. So, but I think an SME or a social enterprise trying to persuade the people, hospitals of that on their own are unlikely to succeed. But where there is a system,
how would you do it then? How would you do
so
it?
I think it is working with the city leaders, with so that the power brokers within the system, the local politicians need to have an agreement that the system needs to change, and then it will happen. But small organisations on their own haven't got a chance, we would say.
So, on your own, you haven't got a chance. What are you going to do? What are you going to take away from this?
I think we'd drawn that conclusion a while back that we didn't really stand much of a chance of doing it. I think we now focus on more self-funded models of care. So it's telehealth services that people can use in their own home and work with funders that want to support that, rather than try and chase the NHS for money when it's not really, we just don't see that it's there.
So, I mean, clearly it's difficult to do, but we pay for activity at the moment. We don't pay for useful activity, and we don't, have commissioning for outcomes. And we need to move to that model, and clearly we've got things that have been running for a while, like Year of Care and so on and so forth. But it's kind of turning tankers. But I mean, the NHS has to move to a system that provides the funds to provide the care in the most appropriate setting. And it's systemic. It's not just up in Cumbria that we see this challenge of how the finances are working against us at the moment. Not to say it was a bad policy when we had incredibly long waiting lists. That was a time ago.
Next question, or comment, or contribution?
Just maybe to give you a less depressing view. In terms of certainly what we've done in Liverpool, we actually set up an e-health cluster for SMEs to support getting access to NHS services and how you actually access NHS procurement and things like that, because it is difficult as an SME to do that, and the biggest understatement I'll make today is probably the NHS is a very complicated system. But start to look at who you're approaching and for what reason and what the drivers are behind that. You've answered your own question in some ways, that you're saying acute services have their own under current contracting, depending on how they're contracted, have a vested interest in maintaining people filling beds. And it's not hard to do. They're not really going out there to do it. There's a big long line of patients waiting to go and fill those beds. But start thinking about how do you engage with primary care. It can be a large GP practice. What about your community service providers out there? They also have a vested interest in keeping people out of hospital and managed at home, which is where your technology can help. And I think, if you see me at the end, I'll give you details of our cluster. We'll be quite happy to talk to you about that and give you some advice about how you can go about doing it. But the change is coming. I think I entirely agree with what Donald was saying. There is a drive towards keeping people well in the community, and there will be a place for your services and technology in the future. So hang in there, but also think about who you're talking to and what your message is.
I was just going to say we've got something similar in Manchester. We have to work with the procurement system we've got at the moment, but some simple advice about where you actually focus your attention can help. And we do know companies that by reviewing the way they're trying to enter the system have actually been successful. And again, as Donal says and Warren said this morning, it's rejigging the whole system to work cohesively.
I think for me, fundamentally, understanding the funding flows is really important for an SME. So, primary care currently holds the budget, but I think SMEs need to be really consider the landscape in terms of how you articulate the value proposition. So it comes back to the evidence base and evidence generation again. So if you've got evidence that actually you can reduce unplanned care, reduce activity, and you can quantify that and use open data sources that the DH has, HSEIC has, to say, actually, this would save you X amount over 1, 2, 3 years, then you've got a really strong business case to go back to, the primary care clinical commission group with. And then also, I think, to understand the impact it could have on community services. So, for example, we have telehealth services, and in fact, improving the productivity of community services so they can take on a much wider case mix, again, is another productivity argument for telehealth and telecare. So I think really just understanding, funding is a barrier, and to understand where the things you need to do to overcome that.
Oh, sorry, okay.
Hello. I'm probably sticking with a similar theme, maybe. I think it's interesting in the audience, if you just look at the delegate list, that it's mainly SMEs and, put it this way, non-NHS organisations in the audience. I wonder whether that's reflective of the challenge that of getting this information, getting this agenda to the front line of people, NHS organisations, because they've got quite a lot on. We all know that. My experience, both within the NHS and sort of outside of it, is that it's very difficult, particularly for clinical commissioning groups, and Liverpool, has more sort of scope to do this. It's a larger organisation, but many are very small organisations, and actually just don't physically have the capacity to look at all of these different ideas and innovations. And so I'm really intrigued, not to be depressed about it, but I'm intrigued how Clive and Donal feel within, say, the Greater Manchester community, that you're going to actually try to really accelerate what's a really intractable problem that I don't think it's necessarily a resistance to change, it's simply a capacity issue in the organisations and myriad organisations that exist to make these critical decisions.
Perhaps you'd like to answer that, Clive and Donal.
Go first. So I think there's a couple of different things. It's interesting, the observation, first of all, sort of the attendees list and the delegates being largely from SMEs, and that could be partly around frustration with being able to access the system. It's also a question of where would the innovation actually come from, and actually should the innovation actually occur within the NHS, or actually should it occur out in the private sector? And actually the reality is it's probably a mixture of both on together in some occasions. In terms of what we can do across Manchester, what we're looking at is to say, are there things where we can identify health needs that we have, and Manchester's not unique in terms of health needs compared to Leeds, Liverpool, a whole host of other cities, so it wouldn't surprise people to know it's ischemic heart disease, it's chronic lung disease, cancer, etc. So having identified certain things, what are the interventions we think we could actually be implementing now, and how do we try and get, certainly for Greater Manchester, the NHS and indeed the health and social care system to act together? So rather than 10 acute trusts, 12 CCGs, 500 GP practices, what are the things we actually think should actually be, the game changer initiatives, or treatments, pathways, screening technologies, prevention, whatever they may be, that we could actually apply, and we should be applying now, that we could then quickly actually work across the procurement system, across the commissioners, to actually be able to implement very, very rapidly. Now, clearly, there's a limited capacity to be able to do those things, and the number of potential opportunities is huge. So, the challenge is, how do you find the best ones for implementing? So that's one of the one, along with Donal and Linda and others at the HSM, we're currently thinking through how do you create a mechanism that can actually find those best ones, that lets the cream of the crop come up through to the top? What's the evidence behind them? But actually, once you've found them, how do we then actually re-engineer the system so that the system can make the most benefit from those? So they're things that we can think of within that sort of that centralised procurement system. the other one, I think there is a point of how much of some of these things will need to be carefully controlled by, for example, the NHS. Clearly, things that are interacting directly with the patient record or other things, they will. Some of these things won't be, and actually, are there some of these things that are more actually business to consumer type products that actually don't need to go, if you like, near the NHS at all in many ways? They almost work alongside, where in the same way as I have, apps on my phone that do a myriad of different things, there will be some things that don't necessarily need full NHS endorsement or other things to actually drive. Now, clearly there's a spectrum from one end being very tied into clinical care and quality of advice and other things, and then the other side is purely consumer. But, there is a spectrum there, I think, where particularly as more and more of the population are more au fait with sort of digital media, actually sort of in terms of online use, running lives online, if I compare what do my parents do to what do my kids do, it's a massive, massive difference. And as we have more and more people who are able to access, and not just able to, but expect to be able to access, and are literate around the internet and all the other systems to be able to find these things, I think there will be an increasing market for some of those things directly to consumers as well. So I don't know, Donald, do you have...
So I agree with all of that, Clive. I guess if I was looking at the audience, and I don't know the full delegate list, but I'd be saying I wonder where the voluntary sector are, where the charities are. I mean, the biggest change agents, the people who've got the biggest stake in it are patients and service users. And I think one of the lessons we heard is that, build it with people who are using the services, citizens, the terminology is a bit of a challenge for us, isn't it? But loud and clear in the, accelerated access report came out a couple of weeks ago, and loud and clear in all of the things is put the patients and the patient organisations in there and help there, and they will help drive some of these solutions.
The question is, has the NHS got the capacity to
the NHS is always busy, and these are busy people, but back to this issue of we're paid for activity. We know that, is it 20%, is it 30% of, the elective activity doesn't add value to the service users? That's, across, it's not just the UK. So we have a system built around interventions that are evidence-based, that are used in populations where it's not necessarily going to be effective. So we have to build that capacity in.
John?
I completely agree with both the points that have been made. And we know, don't we, that most innovation happens at the edge. And the idea that your typical CCG or local authority is going to be driving both the creation and take-up of innovation is pretty fanciful, really. And so we've got to find ways of getting more activity out to the edge. And that means two things. One, more commissioning for outcomes. Because then the providers, SMEs, voluntary sector can define what the answer to the question is for working with the patient or the service user, which might be a piece of innovation. And the second is much more personalisation. So even greater use of personal budgets, direct payments, so that consumers, service users, patients can actually make these choices. But the final thing is, in order for them to be able to do that, somebody's got to curate the market for them. And there's all sorts of ethical issues around that, but you've got to enable people to be able to navigate between products and to make good choices.
So to make just a comment on that, so one of the outputs from Dallas is the Digital Health and Care Alliance, and that has proposed a process for assessing and kite marking apps to the National Information Board, and it's currently under consideration. So I think that if that or something like it is accepted, then it will make it much easier for SMEs to only to have to make the point once and prove the product once, and then busy operational organisations can then have a whitelisted the whitelist of interventions that they can trust and just and include them as appropriate. So,
another question. No, I think the people with the microphones know who's been waiting longest. Okay, great.
Hello, Jonathan Butters. Seeing as a state we're in, and there is admittance that the NHS does have some barriers and some structural issues in adopting innovative services, and I think there was quite a bit of highlighting there that outside of the NHS we could see quite a lot of rollout of these innovative digital services. What's the feeling as to who's going to be the sort of organisation that's going to roll these things out? Is it the supermarkets? Is it the gyms? Is it the mobile phone companies or the high street pharmacies? Where are we really going to see the short-term rollout of some of the great work that's being done by Dallas? Because if the NHS is too slow to move, somebody else is going to do it, aren't they?
Who wants to?
I think it's a mix. Living It Up has various rollout partners, for want of a better word. So we're working with leisure centres, we're working with primary care, we're working with social care providers who are all rolling out various aspects of the service. We're activating practitioners, both in social care and healthcare, and we're passing on digital skills, so we're working with digital specialists as well. So that it really is a mix and dependent on need, and therefore Living It Up is acting almost at the moment as an architecture for how these things are rolled out and informing policy. For instance, in Scotland, I'm going to repeat what Francis said, but if you move up Scotland, there's an active policy of e-health where SMEs are at the centre of the rollout of e-health initiatives. So, and that's very proactive government policy. So I think it's operating at multiple levels, and I know Dave's got some possible comments on that as well.
Yeah, I think it's one of the most incredibly difficult areas that we actually looked at, and certainly the area that we failed at most often and most regularly. I think we had a look at what it meant for technology and how it would work in a retail environment. We had retail partners. We tried and failed. What we came to was, and based on some of the research that we did earlier on, is that it kind of comes down to what market you're aiming at and what the purpose is behind why people would engage with that technology. Is a Fitbit. That's a piece of personal technology, and it kind of goes around people's individual view of themselves. I want to be fitter, I want to be thinner, and that's a high priority for people. What we found is actually health goes up and down the level of priority depending on what state of health you're in at the moment. So actually, if I'm feeling okay at the moment, actually my health's not really a high priority. But I might want to fit into that particular piece of clothing. So therefore, I want to be, I want to be fit or whatever. So all of a sudden, that piece of technology becomes more important. So actually, when you're trying to look at retail and retailing things for a health purpose, it's not got a very solid market or a grounding in terms of the market that sits in front of you. And we found it to be very, very immature. And that's why we're also finding that retailers and people who are going to push this out to consumers don't find it a very secure ground to go on either. And the response that we got is, it's too immature. It's still your job to try and push, as an NHS, to try and push people down the route of adopting self-care technology. I'd rather it wasn't that way. I think if it was out there and people could get it from a variety of different outlets, and that might be the way it goes in terms of it could be a whole variety. It might be B&Q, it might be Maplin, it might be Apple, who knows, the kit that is now available to do a whole variety of things. And I think it's moving in that direction. But certainly, and I'm sure when the evaluation comes out, you'll find there's an awful lot of things that we tried, but we couldn't get the retail bit right. We certainly got the message out there through smart houses and demonstrators about what technology is available and where you can get it from. But people weren't necessarily ready to buy it at that one point in time.
Can I add a word on the behalf of the consumer? And the word is trust. At two levels. At the digital level, who's looking after my data? And a communication company, would we trust TalkTalk to look after our health data anymore? Probably not. But would we also pay Vodafone when, in the last conference I spoke at, 30% of the audience had some sort of issue with them over pricing? So trust. Do you trust bankers, politicians? Well, do we trust any of those big companies, including the supermarkets, to genuinely have the consumer's view at heart? I suspect not. And therefore, the third sector is likely to be the one that comes along with the necessary brand and with the consumer view at heart. So I think we will see these supply chains probably heading up with the end point being a third third sector provider, and the challenge will be perhaps for the SMEs to engage with the charities, to sell it to them and allow them to sell it with trust onto the end user.
So one of the interesting stories within Dallas was our efforts and engagement with a very large energy retailer. And they went quite a long way along the line to deploying services to support informal carers at scale. And so they were nearly persuaded to go with it. And we were very excited about the potential there, you know, to access millions of people and make simple support for informal carer communication.
How would it work? Sorry, just tell us that.
So it was really to allow families who were scattered, to get simple reassurance information like mum's up, she's made a cup of tea, lights are on.
What would the technology have been?
So the technology was sensors and telecommunications, and so there'd be alerts. And so it was a very straightforward proposition. We called it Warm Neighborhoods, and the energy retailer was very excited and committed a fair amount of time and effort to getting it ready. But at the last, late in the process, decided that actually they needed to concentrate on their core business for a number of reasons. Where that Warm Neighborhoods service has now ended up is with more specialized home care providers. And so it's getting successful traction in a more specialized, a more obvious channel than a large energy retailer. So I think it's a matter of timing. I think that some propositions are appropriate for an energy retailer to roll out, and some clearly wouldn't. And they themselves wouldn't go anywhere near health. But enabling families to communicate automatically just to get indicative information about whether people were okay or not, they were prepared to go that way in principle. In practice, it was too early for them. But I do think the fronting, but also, so they also were interested in working with a third sector organisation as essentially the guarantor of the actual service itself, but they would provide the commercial and technical infrastructure.
Lovely. We've 10 minutes left, so I think we'll take more questions and perhaps just take one answer to give more. Let's get some delegates a chance to speak. Okay.
Angel Salazar, CEO of AIDA Technology. My question is regarding what are the activities that Innovate UK is doing in collaboration with other government departments to help SMEs become global players. For example, the download rate for UK is 1% of the global market. And perhaps we are being too inward looking instead of outward looking. Even for the NHS, for some investors and some companies that want to work with SMEs in the UK is too small. So how the Innovate plans to support SMEs in that area?
Who can answer that?
I can do that. It's quite pertinent because you'll have seen at the start of this week, or I think it was in Downton Abbey or something like that, the adverts started coming out about how the UK's ambition to export. And we recognise the fact, and we've always recognised the fact that whenever you look at the development of this type of technology, that it isn't just the UK market that we'd want to target. There is a global market opportunity around this because we see this issue around the world. I think that our role in connecting up with UKTI, with Healthcare UK, and in trying to create the opportunities for the businesses that have got early demonstration of the technology is actually they might find that they'll get traction in more consumer-driven markets overseas, because over there you might not necessarily have the legacy of how health and social care has been delivered previously, and they're more open to ideas being adopted.
Where are you thinking of in the world? Where in the world?
The interesting thing that we've seen is particularly in around India and China, where you're not reliant so much on the state to provide health and social care for you. You're probably looking at either family mechanisms or self-paying. There are real opportunities there where people are actually sort of more interested and more open to these sorts of ideas than where you have an established way of being able to deliver health and care.
Lovely. Should we take another question, comment?
Hi. Excuse me. My name's Helena King, and I work for Age UK. And my job for the last 10 years has been about developing products to the retail market, to the end consumer, products which are about solutions. And we have 3 core product areas: mobility, healthcare and technology. My challenge, because we're obviously a third sector organisation with a commercial aspect of which we're trying to develop more products to consumers, is we can't afford to be able to market in a space. For example, we have a tablet which enables people to get onto the internet. We offer hearing aids, we offer a whole raft of mobility equipment. We can't afford to go against the major players within the market space who have aggressive media and marketing budgets. So where we're really reliant on is the healthcare professionals to help signpost people to us. And my question really is, how do we, who, as an organisation who are actively in this market trying to promote products, work with people like yourselves in terms of being able to get that, that recommendation, people to signpost to us, to know what we do, because we can't go against, for example, Argos's aggressive Christmas campaign with the next best tablet for older people. We can't afford to do that.
Okay, who wants to answer that?
I don't mind having a go.
Well, why don't you both quickly
I'm
answer
happy
it?
to answer that because I also do something similar with the Carers Trust. We're in exactly the same position, and our realisation was that what people need is access to choice. So they need information portals which describe in independent and impartial and informed ways what products do, and allow people to choose where they buy a product from. And our understanding is that people will choose a brand that they trust, and the charities come at the top of that list. So people, it won't be a case of price comparison. It's a matter of people's trust.
But how do you do it's the question, how do you get your tablet out there?
It needs to appear on that database. And as a result of Dallas, such a database has been produced. It's called Vivo, and it will be launched shortly.
Oh, okay, so it's going to be launched shortly, the database that you need. John, did you want to
Yeah,
answer
I mean,
that?
there's more than one database actually. For example, Hertfordshire have got a brilliant portal already. I know Northamptonshire are developing one. So to a certain extent, commissioners will develop, their own approaches, and hopefully we'll join some of them up. But I just want to really put an emphasis on brokerage. I'm a big believer in brokerage when it's done well. It is a way of linking the consumer to the market and to enable them to make good choices. And as I said before, there can be ethical issues around it. It has to be done very well. You've got to avoid all sorts of conflicts of interest. But nevertheless, a good broker can bring the market alive for a consumer and enable them to connect to you.
So who's going to be that broker?
Well, the brokers themselves are commissioned by local authorities. Actually, Manchester are one of the best authorities in the country at using brokerage. And they've got some brilliant brokerage organisations. So it's up to local authorities, CCGs, to recognise the value of brokerage, that actually can save them money in the medium term, even if they have to invest in it up front.
Can someone just make a quick additional point? Karen Worsley from the Disabled Living Foundation. The DLF have a comprehensive database of equipment, including telecare and telehealth. So it gives guidance on the organisation and the technologies. One of the issues we have is that we have brokers who actually know very little about this technology area. And it's trying to get brokers informed about the choice that's available and then enabling them to support the individual to make the choice. Now, the difficulty for any charity at the moment is funding. And so we're having to become more commercial, but of course that is difficult when you're trying to be impartial. So I think you have to recognise it's great to say we should have impartial advice, but how does that work in this sort of increasingly difficult financial situation?
Who wants to answer that? That's obviously a tough one. you waiting?
I'll answer it.
Great, do.
I need a microphone.
Okay.
So my name is Mark Meinard from Moving Essence. So to answer that question, I have a product which will raise money for charities, and I want to raise money for charities. And I will work with you if you want, and you will help people with the product at the same time.
Okay, we have about 4 minutes left, so I think we could take one more question.
Hello, it's Sean McDougall again. I'm very conscious because we're in Manchester at the minute, and you have this unprecedented opportunity to draw together the NHS and the social services side of things and have control over all of it. And that really puts the focus on payment for performance of tasks like spinal surgery versus payment for the outcomes achieved, which may be getting somebody back into work again quite quickly. And I know that in Germany they did some pilots like this with 6,000 operations in 41 different centres, and they paid the surgeons according to how quickly people got back to work and whether they stayed in work for a long time once they went back. And they achieved, I think it was a 52% reduction in time off sick, and it also reduced the overall healthcare budget by 10%.
How did they do? How did the surgeons alter their behaviour to do that, to produce that result?
Well, it's to do with the system design. See, and so my question really is, as you set about taking control of this broader remit, you've got this opportunity to bring a new vision down to bear on everybody. And all the people over here have got a lot of practice at trying to bring a new vision to bear on large communities. So I'm really keen to hear how you propose to make sure that these two institutions don't just walk on under a new name, and whether you see any scope to draw on the expertise of the Dallas community, so that you're not yourselves just spending 3 years in the wilderness, but you can draw on that experience of how to get there.
Who wants to answer that? I could do with one person. Yeah, lovely.
I mean, I guess it sort of plays to the shared decision-making agenda and the issue that we know a lot of interventions don't actually add value, and we can identify those people beforehand. So it's choosing the right people to have those kind of operations on. And I bet they were great at penalties as well, being Germans. But so it's choosing the right interventions for the right patients. And I think precision medicine sort of taken us there, pretty quickly in terms of other types of interventions, maybe not spinal surgery. And then it's saying, well, okay, what is the goal here? And what is the goal as set by the service user, which back to work, back to living properly, and ensuring that we don't just invest in that high end, but we have the rehabilitation end of services there. So we have to redesign that pathway, I think, with the healthcare professionals, with the patients, their advocates, and with the people who've got some of the technological solutions or some of the cultural solutions to, because of their technology, bring those people together around a number of high cost or high volume interventions that are likely to benefit the wider public service. So that could be back pain.
Well, panel, thank you, and Dallas community, thank you, because we're at the end of our time now, but we are on time. I'm sorry if you didn't get a chance to speak, and perhaps some people will be around when the conference is over. Thank you very much indeed. Thank you.